thank everybody for coming this evening. We're very pleased to have you here, and we're anxious to hear from the panel on this difficult subject. We'll let you know that if anyone needs to, if you go out that door and to the right, you'll find the men's and ladies' room. We are planning on this ending in 2 hours, well, at 9:30. We have 6 panelists who will be talking. We'll try to make this a very friendly interchange of thoughts, but I have to set some ground rules, and hopefully people will try to abide by that. So we'll ask each speaker to talk. We'll allow 10 minutes, but we will let you know when 6 minutes are up and 8 minutes are up and when 10 minutes are up. And if you could wrap things up in that kind of frame, that would be nice. That would allow a little over an hour of speakers. If you have a burning question, you have some paper there with you that you want to ask each other, and you think it should be asked right away after the speaker is completed, we will be glad to honor that. But we do want to have respect for all of you speakers, so we don't want too much time on one issue. I thought I'd start off, the title of this talk is Medicine and Politics. And I thought I'd tell you about something that you probably don't know anything about, maybe one or two do. 50 years ago this summer, I finished my residency in internal medicine and went into oncology at Johns Hopkins. But just as I was finishing my residency, I was moonlighting with a general practitioner near Annapolis, Maryland. I was at the University of Maryland. And I worked Friday nights and Saturday mornings with him. And he would charge his patients $3 for a routine examination and $5 for a more complex examination. And they paid at the front desk. And he said to me that if Medicare didn't come in until 3 years later, and he said, if I can collect 70 to 75% of what we ask our patients to pay, it's a good day. But of course, he did get something done. You know, his lawn got mowed, his car got repaired, his haircuts were less expensive, perhaps. But that was the way medicine was practiced then. Now, there were no politics in medicine then, but there was a lot of paternalism. We physicians knew the answers, and patients fully agreed, never questioned what we're doing. So some changes have occurred, but unfortunately, some things not so good. There is the patient, there is the medical team, and then there's government that are working on these situations. So that's what we're going to discuss. You have in front of you the list of speakers. We're pretty much going to go in the order that they're listed here for no special reason. Just that's the way it is. And the first one will be Terry Belmont, who is CEO of the hospital and Associate Vice President for Medical Center Affairs. Okay?
Thank you. Thank you, Ron. It's nice to be here. Can you hear me okay in the back?
If you come out, let me know.
Yes, please let me know. I think it's neat that you're all here. I had a chance to meet Al Wolf when we were walking in together, and I said, "Why are you here?" He said, "Well, I like to learn, and I'm interested in the topics," and we were able to talk a little bit. And I also, Dr. Coons has been a member of the medical staff and of course faculty, and Dr. Coons is so important to us in the role he plays in terms of ethics at the medical center. And I know he would love to play a larger role, and I'd love to have him play a larger role. And how can you say no to Dr. Coons? And then of course Dr. Clayman said, my partner next to me, who's the dean of the medical school, said, I know I'm taking my 10 minutes, but I want to get going here, get the energy going.
As long as you're saying nice things about me,
and Dr. Clayman said, it'd be good for us to come together because we are partners. And medicine...
I said misery loves company, right?
Oh,
I think those were my words.
But you know, healthcare is really a partnership. It's a partnership with physicians and with nurses, with practitioners, with providers. And healthcare is really changing a lot And the way it's changing is, I think, more into a partnership. And so I'm going to share just a little bit about what I think is one of the most important aspects of healthcare reform. And whether you're for President Obama or Governor Romney, I think there's some principles that we need to be following as we go forward in healthcare. So I'm going to discuss that. But I do also want to say that I was privileged to become CEO of UC Irvine Medical Center about 3.5 years ago. And my first day on the job was as CEO was to, I got in, my first day on the job, I got in there about 4 a.m. in the morning, 3:30 or 4. That was the day we were moving into the new medical center. How many of you have seen the new medical center at UC Irvine? So most of you have not. And the old UC Irvine Medical Center was 3 and 4 bed wards and in an older building. The new UC Irvine Medical Center is primarily private rooms, 7 stories high. You might drive by it on the 5. You may or may not know you're driving by it. And it is the most modern, well-equipped, technologically hospital. And even though there are some newer ones now, it is the most modern, most technologically equipped. And it's an incredible place, and it really befits the kind of quality care that our physicians provide there. So that's just a little bit of, that's not a commercial, but I wanted to know how many of you have seen the new medical center, and very few of you have. And I would love to have you come over, and I'm making an invitation to you now, and somehow we'll get my email address to you. I'd love to have you come over and give you a tour of the new medical center, because it's absolutely incredible. So I was really blessed to be able to be there the first day we moved in. Today I'm going to talk about value-based healthcare, and I'm going to talk about the triple aim. How many of you have heard of the triple aim? John has. Very few. The triple aim is talking about the fact that what we need to focus on is first of all, the health of population. And that is, what's the most important thing about what we do in healthcare today? Healthcare today is not just taking care of a sickness right now, but it's really working to keep a person healthy as they can possibly be, based upon whatever condition they may have. So if a person has chronic health or coronary heart failure, heart disease, whatever, diabetes, how can we help them have the most highest quality of life they can possibly have, and not get to the point and keep them in a manner that they can have quality living without having to go into the hospital, going into the emergency department, whatever. How can we try to avoid that? And then when we see patients in the medical center, let's get measured on how healthy we can make them and keep them, as opposed to just taking care of their immediate problem. So health of a population is a part of the triple aim. Another part is, and a key part, is the experience of care. We all go in, whether we go into a restaurant or whether we go in, anywhere we go, we assume certain levels of quality of care or service. We assume the food's edible. We assume that we're getting fairly good quality of whatever's happening. But what we care most about, so we care about that, but what we also care about and how we can really measure what's happening with us is the service. If people communicate with us what's going on, if people let us know, here's what you can expect when you are coming in, I'm going to use the hospital or a physician's office, here's what you can expect while you're here. We're going to give you a test. You will go through surgery. Here's what surgery is going to be like. Here's how you're going to feel when you're finished. Here's how long you're going to have to stay here. And here's what happens when you go home. If we know what to expect, if people share with us, if they communicate with us, we care a lot about that. And you know what we care a lot about also is smiles. We care about you looking at us as a human being, that we're a person, not a patient, but a person. And we are, or our families are people, not just somebody who's there with the patient. And so the experience of care is another key aspect of the triple aim. So triple aim is service, treating a person like a human being, and it's also health, really focusing on not just the experience they're going through right now, but really how does this relate to their health as time goes on. And the last piece, guess what the last piece would be in the triple aim? Can anybody guess what that might be?
Prevention?
What'd you say?
Prevention, he said.
Did somebody say money?
Money, I said.
Money and cost. Somebody said cost and money. So the last piece is cost. Because we can get the best, well, we can get whatever we get, but if we can't afford it, then we're not going to get it. So the other piece of the triple aim is cost. What's the per capita cost? And so those are the three pillars of the triple aim. There's another way to say it, and it's value-based care. And value-based care is quality plus service divided by cost equals value. That's another way of saying it. And that, to me, is the most important part of healthcare reform. When it comes to, there's a lot of, you've heard all the discussions about how do we pay for, what about Medicare and the cost to the government and so on. There's huge issues there. They're huge. But a direction that I personally feel is a really critical direction is how we provide care in the future. And I honestly believe that we need to move from how many procedures, we need to reward, let me put it a different way, to our healthcare providers, not how many tests are given, but how healthy the population is. I see a person in the audience who is an outstanding executive, who was an outstanding executive with a insurance company, who focused on, we will pay physicians and hospitals so much per month, and what we want you to do is keep those people healthy. We're not going to pay you for the number of procedures you do. We're going to pay you so much per month, and if you keep a person healthy, you're going to be successful. And that is truly, in my view, a real important aspect of how healthcare should be delivered in the future. I know this is very controversial to a lot of people. Right now, most of us get paid on a fee-for-service basis. So you come in, you get a service, you get paid for it. Healthcare reform is really focusing on, we will take care of a number of people, and for this price per month for each person, we will do our best to keep that person as healthy as they can possibly be. And when they're not healthy, when they are in a period, I know time's up, so when they are in a period of extreme discomfort, extreme bad health, if they are in the period at a point of acute, getting ready to pass away, you take care of them. That's a part of it. So anyway, I could go on and on, but that's a start in terms of I will be happy to answer any questions as time goes on. But I wanted to put that out there for everyone to think about.
I think you're saying that we all say the premiums that we have to pay for health care are too much, but when I go in the hospital, I want everything. And we don't realize the two are not harmonious. Thank you very much, Terry. Graham Bushy is going to present the next talk. He's Assistant Professor, Department of Political Science, and I'm going to ask you the question that I should have asked before, sorry. How does the American state government handle complex health policy challenges?
Thank you. And first I want to say is that I'm newly arrived to University of California, Irvine, by way of University of Michigan, where I spent the last 2 years in the Department of Health Management and Policy studying healthcare reform as a Robert Wood Johnson Scholar of Health Policy Research. And I can't emphasize enough what an exciting time it was to be a political scientist in a school of public health, where the stakes of the debates we were having were very real, and the substantive issues we were discussing had immediate policy impact. And when I say immediate, many of the people I was talking to were directly exchanging ideas with the Department of Health and Human Services in developing the health reform legislation. Being a political scientist in a school of public health at this time gave me tremendous appreciation for the perspectives of the broad community of people in public health and medicine. So I'm very pleased to be on a panel like this and learn about the perspectives. But as a political scientist, I'm obviously going to talk about government and perhaps flip the way we think about the role of medicine in politics to instead ask how medicine or the scientific community can improve policymaking in the United States. And the question I've wanted to discuss today is how U.S. state-level governments work to handle complex health policy challenges. And I'll give you some background which leads me to this question. The first is that I'm a native son of California. And being raised here, especially from my formative years, 1990 through 2012 today, I've seen what I consider to be an alarming hostility for the role of government in the public sector. We've become very skeptical of the ability of government to resolve social problems. We believe that government is a regime in Sacramento dictated by cronies and special interests who pursue policy for their own objectives rather than for the public interest. And California voters in 1990 passed Proposition 140, a term limit legislation that we've recently revised, but one which also attacked the apparatus of policy expertise in Sacramento. It gutted the staff given to the Legislative Analyst's Office. It cut the experts afforded to committees and individual representatives in Sacramento. We've been pursuing a series of policies in California and across state governments which cut the resources given to our policymakers to analyze complex public health policy challenges. So at the state level, we're in an era of retrenchment. We imagine with halcyon eyes citizen legislatures that are based on the expertise of the everyman rather than professional politicians or policy experts who've been trained to address complex public health challenges. The other interesting thing is that there's tremendous variation across state governments. California, although it's been deprofessionalizing, remains one of the most expert states in the country for handling policy challenges. This is happening at a time when the federal government has enrolled one of the most ambitious public health reform legislations in decades. The PPACA, Obamacare, which he is now taking ownership of proudly, is a remarkably broad piece of legislation that at the moment of writing, the authors pushed through incredibly quickly. Can I ask anyone why they think that Obama administration plus the House and Senate pushed that piece of legislation through quickly?
They control both houses of Congress.
It was a short window of opportunity. They had unified government that they knew was fleeting. 2 years down the road, they expected to not have this moment of opportunity, which means that they delegated lawmaking to bureaucracy. The Department of Health and Human Services is hemorrhaging regulation. Regulations carry the weight of law. Tens of thousands of bills directed to state governments, directed to change the behavior of state governments, and directed to encourage state governments to implement wildly complicated policies such as insurance exchange regulations, Medicaid expansion, and other preventative public health policy measures. So here we are in an era when government is delegating to the states a wildly complicated set of policies, a period where state governments have unequal expertise and unequal capacity to handle this legislation. So how have state governments handled this? And what we see for those political scientists who have studied this is that there appears to be a real value in state governments investing in expertise, both in scientific policy making and in public health policy making related to insurance exchanges. One of the challenges we're seeing is that state governments have very little idea how to implement Obamacare's chief central provision, the insurance exchanges. They've delegated this task to insurance commissioners. Insurance commissioners are not tasked with regulating a medical insurance market, but they have been chosen as the most opportune person. Many of these insurance commissioners are independently elected. They are not of the same party as the governor, meaning that a Democrat governor expecting to implement health insurance reform in a state like Montana or North Carolina after November 6th may have a Republican insurance commissioner that is going to obstruct every effort to implement Obamacare. The only thesis I want to impart on you today is that the variation across state governments has a tremendous impact on how state governments go about handling complex public health policy making. What have we learned? Well, dealing with issues other than Obamacare, I can speak with some confidence that the investments America's state governments make counterintuitively in expertise has a beneficial effect on the type of policies they pass in preserving population health. Research in political science says that legislatures that have more expert staff with backgrounds in public health, legislatures that invite the participation of the medical community, have done better in adopting innovations to address the crises of tobacco, of immunization, of infectious and contagious disease control than states that have not made these investments. Even more ironically, states that welcome a broad participation of interest groups, participation of the Kaiser Family Foundation and the Robert Wood Johnson Foundation, two foundations dedicated to health policy improvement, as well as the American Medical Association or Pediatric Association, and goodness forbid, the tobacco lobby associations end up producing policies that again yield compromise and push policy forward. States that have deficits in either the expertise or the interest participating in politics end up having one of the two groups dominating. So there's a sweet spot. We want the publics to participate in policy, but we also want state governments that are invested in expert, savvy, scientific communities setting policies related to public health.
Thank you very much. That was very good. Our next speaker will be Dean Ralph Klayman, who is a professor of urology and dean of the School of Medicine. And Ralph, do you believe that the current model of medical care delivery is sustainable? And if not, what alternatives do you envision?
Thanks, Ron, for asking me my question.
I'd almost forgot I'd asked it.
From my standpoint, what I'm seeing is an unsustainable system. And I've sort of slowly gone through an evolution over the last few years, because I have to admit, when I was in urology, I really wasn't concerned about any of this. I was just concerned about taking care of people. And that's all that I wanted to do, and that's all I cared about. Now I'm in a situation where I'm very much concerned about what's happening, because I'm training, in essence, I'm responsible for over 400 medical students who are going $140,000 in debt in order to come out of medical school and take care of people. So now I'm very much concerned about what's going on. My feeling is that we always, when we talk about healthcare, it's one word, and the word makes no sense. If you have your health, you don't need care. If you're getting care, you're obviously not healthy. So when we have this concept of healthcare as one word, and it's just, in my mind, wrong. It should be broken in two, and you have health on one side and you have care on the other. Care is really expensive. It's sucking up 18% of our GDP. Good health is relatively inexpensive. We don't even really have a handle on it, but it doesn't cost a whole lot. But it does depend very much on the person doing something for himself or herself, rather than a professional doing something for you. And so to be healthy, You've got to take responsibility and accountability for your own state, if you will, as opposed to care where you put yourself under the care of somebody else to try and make you healthy again or to keep you healthy. From my standpoint, you need to look at the provider, the person, and the population. So I have health here, care here, and then the side markers are provider, person, and the population. The providers on the care side are really expensive. Physicians, nurses, nurse practitioners, PAs, hospitals, lots of technology, really, really expensive. The providers on the health side are inexpensive. We're talking yoga instructors, nutritionists, personal trainers, mindfulness individuals who can teach that, stress management. That's really inexpensive. We need more focus on that. We don't have any government policies that will put a nickel into that. All of our money is going over here on the care side, and none of it is going on the side that perhaps could avoid the care side altogether. I think we are starting to get into the age of, if you will, what Leroy Hood calls P4 medicine. I call it P6 because I came up with another 2 Ps. But it's proactive, it's participatory, it's personalized, it's precision, predictive, and preventative medicine, health. Not medicine, but health. And this involves individuals who basically are going to help you eat healthy, help you to exercise, help relieve your stress. And indeed, individuals, perhaps my first-year medical students, who can take a history or physical from a healthy person, and today can do a diagnostic ultrasound and basically pick up a small tumor in a kidney or a liver, can pick up a carotid artery that's thicker than 1 millimeter, that's predictive of you having a stroke probably within 5 years, and perhaps recommend that you might want to take half an aspirin a day. That's really cheap. And we've actually got a study that we're going to start with what we call health catalysts, which are going to be our first-year medical students. The other thing is the place. Care occurs in hospitals, very expensive, offices, very expensive. And it occurs over a short period of time. But that's not where the people live. People live in their homes and they live at where they work. That's where the health people need to go out. That's where our health catalysts should be. In industry, they should be at your place of work, and you get an hour off every quarter to visit with your health catalyst, whose only interest in life is your health, and you're part of a health cohort. We've got Weight Watchers to help people lose weight. We don't have any health watchers to help people in a cohort with peer pressure to basically stay healthy. That's cheap. We don't have that yet, and I think we really need it. The other thing is we've met the enemy and they are us. We cause our own diseases. We're encouraged to cause our own diseases by eating at McDonald's and Popeyes and fast foods and eating as much meat as you possibly can. And 1/3 of our population is overweight. What comes with that now? It's taken us over a century to realize that the mere being overweight of 40 or 50 pounds, what does it bring with it? Hypertension, which causes strokes and heart attacks, diabetes, hyperlipidemia, which leads to vascular illness, and for me, which is really good, kidney stones, because I take out kidney stones. But I mean, all of this is correctable by doing nothing more than saying, okay, I'm going on a vegetarian diet, or heaven forbid a vegan diet, and I'm going to basically get and develop a normal BMI. And if there's anything that anyone in this audience does tonight, you ought to go out and rent the movie Forks Over Knives and sit and watch it in an hour and a half. You're not going to be a carnivore or an omnivore anymore. You're probably going to be a vegetarian. And you may even come out of that theater becoming a vegan. But I can tell you this, after that movie, it's very, very impressive. It's impressive to watch a guy who's 55 years old, 45 pounds overweight, who's taken insulin, who's on 6 medications for his hyperlipidemia and his hypertension, go on a diet, lose all that weight, lose basically 40 or 50 pounds, blood pressure's normal, lipids go back to normal, and he's no longer diabetic. Now, what's the problem with that? Who stands up and applauds that accomplishment? Does the hospital applaud it? Do the nurses applaud it? Do the doctors applaud it? No, they've lost business. Do you think Pfizer or Lilly is happy that this guy is off 7 meds? No. Do Do you think McDonald's or Popeyes is happy because no one's buying fried foods anymore? No. So where's the lobby for you to be healthy? I got another 2 minutes, don't I, Ron? Yeah. Yeah. The soybean lobby in this country is extremely small. I've yet to meet anybody who's a lobbyist for organic farmers. The beef lobby is huge. The lobby for the pharmaceutical industry is huge. The hospital lobby is huge. And so the bottom line is, the only people in this country that want you to be healthy is you. The industry has no interest in it, as far as I'm concerned. And that's the way it looks to me. And I haven't seen anybody to convince me otherwise. And finally is population health. We need to develop healthy communities. We need to put in more places to run, more places to bike. We need to be concerned about the health of the community as a whole. We need to begin to look at health as a performance art. And we need to admire, respect, and applaud those people who are healthy. We need more peer pressure to develop healthy communities. And that's about all I have to say.
Can we have a comment? Since to make it lively, because I agree with everything you're saying, but I just want to say nurses will applaud that. And I really say that passionately, that is what nursing does. And that wellness and health promotion is what we do. We don't get paid a fee for service. That's not our business. So actually, we have an incentive to keep our patients healthy because we don't get paid anyway. I'm not talking about nurse practitioners, I'm talking about nurses. And so I agree with all of this, but I'd like to bring nursing into that. That's just one thing I wanted to say.
Well, thank you, and I would want to bring in hospitals, because hospitals, where they're going.
I think I've insulted everybody. Hopefully so. It's an
That's where enlightened hospitals are going.
Yeah.
So we're on the same page.
Well, and that's quite right, because we're going from volume-based payment to population management.
Right.
And that's going to change the whole paradigm, but getting there and the road there is extremely tortuous and perilous and frightening for a lot of us.
Yeah, it's frightening to me. I went to the hospital to get well, and you're telling me I've got to take care of myself and get myself well with a little help.
How old are you, Ron? I mean, for God's sakes, I mean, you're no longer an adolescent and you don't have your parents. You've got to take care of yourself.
I've got a wife, though.
I mean,
And 2 sons. No, but
I mean, but seriously, we've got to take responsibility for our own health.
Absolutely.
I mean, obviously, unfortunately, a lot of us genetically have a genome or something that's going to predispose us to things, but the beauty of what's coming down the pike is in less than 5 years, everybody in this room will have their genome done for under $500. You'll know if you're at risk for diabetes. You'll know if you're at risk for colon cancer. You'll be able then to decide when to start screening for these diseases. If you've got the gene for diabetes, you may decide on a specific type of diet before you get it. You'll have the opportunity to actually cheat the disease that's in your genes.
But we shouldn't even get into the position where diabetes would be a threat to us, other than knowing our genetic.
But there's some genetic things that are there that will predispose you.
We don't want to get overweight to begin with.
Right.
We want to control that.
And it's the same thing with colon cancer, breast cancer, whatever. There's certain genes that will give you a predisposition to that. So that if you're, right now we do colonoscopy. Oh, you're over 50, you're going to get a colonoscopy. Damn, I don't want to turn 50. I think I'll be 49 forever. But the thing is, though, should you get a colonoscopy if your genome says, listen, your chance of colon cancer is extremely low? No, for you, screening maybe should start at 70. On the other hand, if you have a gene that predisposes you to colon cancer, you may want to start your screening at age 30. And we will finally have this knowledge so that we will actually enter a proactive rather than a reactive situation with regard to our health. But the people on my side of the health, they have people. They don't have patients. That's the difference. In health, you have people. In care, you have, if you will, your patients, because people, they're ill, and we call ill people patients.
Graham, did you?
No.
Okay, fine.
So much to react to in that 10 minutes that we'll just have to wait until discussion.
That's why I brought Terry.
One of the
I
most
need some
optimistic
protection.
presentations.
Alex Keenan, the graduate student who's had some experience in, with aging and with long-term care, is the next speaker. And your question is, what is the current status of aging and long-term care and nursing care policies as it relates to Medicare, Medicaid, the Affordable Care Act, and healthcare policy in general?
Hello, everybody. My name is Alex Kina. I'm a PhD student here at UCI in the Department of Political Science. And I feel really fortunate to follow Dean Klayman, because I think it's a pretty good segue, my question. So I was fortunate enough to be an ombudsman for long-term care facilities while I was an undergrad in Chicago. So that allowed me to have experience going into nursing homes and advocating for elderly residents of Chicago area nursing homes. So I thought today maybe I could just speak a little bit about the state of long-term care, which it really is the exact opposite of the future that Dean Klayman has sort of outlined. And in many ways it's deeply flawed. So maybe I'll start with some of the basics. In America, long-term care basically works in two ways. If you have money and if you can afford it, you basically can pick and choose a pretty good nursing home, and you can rest assured that you're going to be taken care of. Or if you have insurance, if you can afford to buy insurance, sometimes that will give you a leg up. But if you don't have any money to pay, this $7,000 a month it takes to get nursing care, then your only opportunity is to go on Medicaid. Now, Medicaid, unlike Medicare, is a program that's administered by the states. So each of the 50 states in the District of Columbia have separate guidelines and eligibility levels for what is required in nursing care and who's eligible for Medicaid care. And I can really only speak on behalf of Illinois, since this is my experience in Illinois. But Illinois, I think, is probably similar in other states in that you have to be pretty low income in order to afford this. And I think the eligibility guideline was something like $2,400 a month. If you made more than that, you weren't eligible. So what your option is, if you're 60, over 60, you basically have to sell all of your assets and hand them over to the nursing home in order to pay for your care while you're in a nursing home. And I think this highlights a lot of the problems. Some of the problems I saw with the current system of nursing care in Chicago was, with the assets, there were spouses, there was issues with, let's say an older gentleman has a hip injury and has to rehab for several months in nursing care. Well, his spouse might have to sell off a large portion of their joint assets, and we're getting into all sorts of problems with family issues and sibling feuds as far as what happens, after mom or dad passes away. But I think largely most of the problem nursing homes that I encountered while advocating for residents in Chicago were the nursing homes that were driven purely for profit. And I want to air this out, that I don't have anything against for-profit nursing home care delivery per se, but in my experience, the way that payments were handed out by the state really led to a lot of problems. And basically, the one common model that I experienced outside of Chicago was a sort of factory, a sort of warehousing of nursing home residents. And the logic was to basically minimize the amount of staff that would have to be paid salaries, minimize their wages, and maximize the number of people in the nursing homes to the bare minimum standards of the law. And the sort of problems that I came across were, there are very few CNAs, there's a high turnover rate for CNAs in nursing homes, this led to all sorts of problems with quality of care for some of the residents. For instance, there was a lot of neglect. Maybe a resident who, was quiet or didn't speak up or wasn't able to speak would only be seen, once or twice a day. And then sometimes, there's cases of neglect where it was much worse than that. And I feel, even though I can only speak on behalf of my experiences, that this sort of system really puts an emphasis on off of the person. In other words, it creates a system in which it's not a person-centered care. People are more treated like objects or sources for profit. And, there's also certain alarming issues that I refer to as the nursing home trap, where you have maybe a homeless person or a resident who had mental illness problems, and they were not able to advocate for themselves. They had no family, or they lost touch with their family. So they ended up living in these nursing homes for years and years and years with basically no exit. So nursing homes, in this sense, become a trap door where you come in and the owners of the nursing home have no incentive to release you. So the resident would get stuck. I saw residents who had been in nursing homes for over 20 years, and they said over and over again, I don't want to be here, I don't want to live here. But there's basically no way out, there is no solution. The only solution for people with mental illnesses who are elderly was to get on public aid and to be sent into these nursing homes. And there's another troubling tactic that I saw administrators of nursing homes use, where if a resident was too much of a problem resident or voiced too much complaints against staff members, they would use a loophole in the billing system where they would send that resident to the psych ward at a hospital so that Medicare could cover them for a certain amount of days, long enough to where Medicaid would keep paying the nursing home for the empty bed. And that was a sort of tactic to say, let's get this resident out of here and put them off somewhere, and we can still keep our payment flowing in. But again, I can't speak on behalf of the whole system, and I realize Illinois doesn't have the most pristine history when it comes to honesty and their bureaucracy. And actually, even while I was in Chicago, the regulatory agency, Public Health, who sanctions nursing homes and inspects nursing homes, there were a couple of public health workers who were actually indicted on corruption charges for sort of turning the other way when a nursing home had violations and they were receiving bribes. But so I guess now I could shift and talk about the future of nursing care as far as the Affordable Care Act. And unfortunately, I don't see any major systemic changes to how we deliver long-term care in this country. There are some efforts to sort of streamline the Medicare, Medicaid billing processes, but these are mostly grants for state innovation. And there actually is another program that makes me optimistic called Money Follows the Person, which is sort of geared to prevent this nursing home trap scenario, where basically if you've been in a nursing home for a set number of days, I think it's 90 days at this point, then you're eligible to have Medicaid pay for in-home care if you can live on your own and still maintain an independent lifestyle. But unfortunately, in our society, death is a taboo, and aging is something that we don't really like to talk about. So, in my opinion, I think that we really need to have a public discussion about what are our values, what are we willing to, talk about when it comes to quality of life at the end of life and aging. And this is a subject that I think if we keep ignoring, then we're not going to see much reform in long-term care.
Thank you, Alex. Hello, everyone. I'm Mahtab Jafari. I'm an associate professor with pharmaceutical sciences, and I'm going to, coordinate or moderate our last two panelists, and then we will open the floor for questions. I wish I had a nice story to share with you as Ron did, but Dr. Clayman, I have become a vegetarian for the past 4 weeks. But I tell you, every time I pass by In-N-Out, it's very hard. Because my car almost automatically wants to go to the drive-thru.
Is it the meat or the fries?
So this is what I was thinking actually Saturday. I was thinking that I could still go there and eat the French fries because that's vegetable, right? So I was thinking about doing that.
I mean,
It's a little dirty.
Let me just preface things and come clean. I mean, you know, I do not believe that a piece of meat once a month or whatever is going to kill you. It's every single day that's a problem. And so everyone's got to find their comfort zone here, if you will. But what has impressed me is that it really doesn't. I don't sit there craving a hamburger or a steak. I really don't, which amazes me. Now, if in order to stay healthy I couldn't eat chocolate, I'm a dead man. That's never going to happen. But it is interesting that you go on that diet and you go, well, it's going to be difficult. And it's not a difficult diet to follow that way.
I can guarantee you that it's not a difficult diet because I love to eat. And but as far as health benefit goes, I started this vegetarian diet with another friend of mine. And none of us have lost any weight. But we feel healthy, and
if you lost any weight, you would disappear.
No, but we feel healthy and more energetic, and I think that's important. So I thought since I don't have a story, I share my vegetarian experience with you. I would like to introduce our next panelist, Dr. Ellen Olchansky, who is a professor and also the director of our nursing program here on campus, and a very dear friend and colleague of mine. So I would like to ask you a couple of questions. The first one is, what will a transformed healthcare system look like with a greater emphasis on illness prevention and health promotion? And this is such a timely question with Obamacare.
Right. Thank you, Mahtab. And I think this follows on the whole conversation, which is actually why I jumped in, because I think a transformed healthcare system is going to emphasize exactly what Dean Clayman talked about, but I feel very strongly that a lot of the roots of this are in nursing, that nursing's roots are actually in caring, in holistic health, and in evidence-based practice. Florence Nightingale was a statistician who collected data, who really cared about documenting the care, and talked about making the environment conducive to the health of the patient. Things like ventilation and creating an optimal healing environment. And I think that those are the things that we need to focus on now in a transformed healthcare system. And I think the Affordable Care Act is emphasizing that there is a focus on recognizing that health happens in the community. People get discharged from hospitals earlier. We know there's more chronic illness with the rates of obesity, just as what was discussed. 1/3 of our population is obese. You know, people go through In-N-Out burger. They don't even have to get out of their car, so they don't exercise, and then they eat this food. And so we know that chronic illness is a huge issue. And with the Affordable Care Act, there's going to be, I think, more of an emphasis on trying to prevent chronic illness, so that there's going to be more of an emphasis on care in the community. The problem is, I think we're all in this room very educated, and I think we know what we should do and what we should eat, but I'm not sure that it's so easy for the average person in the community. That we have to look at the social determinants of health, the social context in which people experience their health. And so that's why I think it's actually complex to provide care in the community for people to help them make behavioral changes. It's not easy. We know that 95% of the people gain their weight back. So we need more of a focus, and I think that's what a transformed healthcare system will allow us to do. That we will truly value keeping people well, we'll develop a healthcare system rather than a sick care system, we'll embrace all the health professions, such as nutritionists, physical therapists, wellness coaches, nurses, physicians, nurse practitioners, physicians' assistants, and we will implement also the transitional care model, which is when patients are discharged from the hospital, we don't just discharge them and forget about them, but we follow them in the home. The transitional care model is talked about a lot, and it was developed by Mary Naylor, who's a PhD nurse at the University of Pennsylvania. And so I think that the nursing part of this is critical. I guess I could keep on going on, but are you going to ask me my other two questions, or actually they all kind of go together? I could just keep talking.
You addressed actually two topics with the first question, but a burning question that I have, because I teach molecular pharmacology to our students on campus, and usually in the middle of my class, my students ask me, how could you teach pharmacology and be affiliated with pharmaceutical sciences and yet be so anti-drugs and anti-medications? And I tell them, because as we've been hearing, health is about, we should just stay healthy. We shouldn't go to the care part. And it's all about prevention. And I really believe in a holistic approach to medicine, and integrative medicine and alternative medicine. So you combine alternative medicine and Western medicine, you have the integrative approach and a holistic approach. And that, to me, that's considered a very good care model. So my question to you is, how could we do that? I mean, with the current situation, Accountable Care Act, and what's happening right now, how could we approach health holistically?
Okay, yeah, because that was one of my...
And get reimbursed for it. No, I'm just kidding.
Yeah, I can't answer that part. But yes, I think that that an integrative or holistic approach to health, it actually follows on what I just talked about, wellness, because I think if we have an integrative approach, we're looking at all the different modalities to keep people well. Sometimes there is a reason to take medicine. If I have like a really bad headache, I'm going to take ibuprofen. But you know, I also try to do things like mindfulness-based stress reduction. And I think for certain patients, oncology patients is a great example of patients who can be undergoing chemotherapy, but also undergoing, having some holistic approaches to help them manage their pain. I also think that the holistic approach is not just individual treatment such as acupuncture or meditation, but it's recognizing the whole person. And it is also an approach to care in which we recognize the agency of the patient, or that the expertise that the patient brings to the whole encounter, that it's the patient who's experiencing whatever they're experiencing. And we as providers need to help them come to decisions that are right for them, so that we can offer them certain options, such as mindfulness-based stress reduction, nutrition counseling, exercise counseling, maybe aromatherapy, lots of different things. But we can't force it down. They have to decide what they want to do. And I think this is all based on principles of psychoimmunology and psychoneurology, where we know that there's an integration of body, mind, and spirit, and that that everything is integrated, and that's all related to this idea of holistic health, that we're not just treating a disease. I mean, if someone has a disease, it needs to be treated, but we also need to recognize the whole person. And I think that also relates back to the health in the community. If we're trying to help an obese person make a behavioral change, I don't think it's going to work to just say, do this diet, we have to, or do this exercise, we have to find out, can they even afford to go to a gym? Or maybe they don't need to go to a gym, but they could just have gym shoes and go outside and walk. But what's the neighborhood like? What's their whole situation? And that to me is holistic care, integrative health, looking at the whole person and looking at mind, body, spirit, looking at the social context.
Thank you. And last but not least, I'm going to introduce Dr. Leslie Lindgren. She's the only lawyer in this panel. She's a senior lead attorney at Public Law Center in Santa Ana, California. And the question that I have for you, and I know this is very close to your heart, is what is the role of LIHP, low income health programs? And what can we learn from it? And I guess the other question is, what is the role of the consumer when it comes to that program?
I'm going to start off with maybe a little spark of light and talk a bit about what's happening in Medi-Cal right now in California. To spin off of what you were saying, Medi-Cal, as we all know, is the health care for the very low income person. And up until very recently, it is today a categorical coverage. In other words, if you're not pregnant, if you're not a child, if you're not disabled, you don't have it. So you can be an extremely sick, extremely poor person, but if you don't fall into one of those categories, you don't have coverage. That, in part, is the genesis, right, of the Affordable Care Act and the individual mandate and all that. And what is happening, obviously, in the Affordable Care Act is an elimination of these categories to make low-income people who are healthy have access to care, including preventive care, the kinds of things that will keep people healthy. There is something that is called an 1115 waiver that was entered into in about 2005, where California negotiated with the federal government to provide certain services that were outside of the regulatory schema and to get them funded. That went forward and was expired in 2009, right about the time that the Affordable Care Act was passed. So that 1115 waiver was extended and is in place today. What it did was allow for the enrollment of some people who would otherwise not qualify for Medi-Cal today in Medi-Cal, people who didn't fit in the categories. So we are in California today actually enrolling people who into Medi-Cal or whatever the county that you're in chooses, however they choose to operate this program. And they've got a lot of discretion as to how they do it. There are people being enrolled into a variation on Medi-Cal that allows for people to be receiving care today that would not otherwise qualify under Medi-Cal. So in the state, you can go online and look up Low-Income Health Plan, otherwise known as LIP or the Bridge to Reform, and you can get data for what each county is enrolling. There were 10 counties that were mandated to participate in this, and Orange County is one of them because they're sort of the original counties. Many counties are not doing it at all. Some have opted to be in. So LA, as you might expect from its population base, has something on the order of 200,000 people enrolled today. Orange County has something on the order of 40,000 today, and kind of matches up with San Diego, which kind of makes sense. So this is rolling out, and it's a great thing. But the thing that I've had the opportunity to watch, and let me just say right here, the people who are working to roll this stuff out, these people are very smart and working very hard and dedicated to doing the best possible job. But it's really complicated. I gave you a handout, which I skipped over one, that you don't have to actually be able to read it, okay? It doesn't matter what it says. This is the schema for enrolling in LIP. This was from a presentation put on a statewide training by the Asian Pacific Islander Institute. It's, I mean, there's a lot of areas for error here. And the point I'm trying to make is that what we're talking about doing here is eating an elephant, okay? We're biting off really, really, really large chunks. And we're going to have to take care as to how we do that. Because the possibilities for error, the possibilities that the individual gets left in the dust somewhere are substantial, I think. And so as I said, the LIP program has rolled out. It has had a few problems. But one thing that I've noticed is the problem, how do you actually get data upstream from the patient slash client slash the provider on the ground who's seeing the problem? How do you get the information upstream as to what's happening? The traditional way to do that, really, these are appeals. You have a hearing structure and you appeal to your local entity and you appeal up from that. That's not a very, and you know, my peers may object, but I don't think it's the best way to do it. There has to be a better way than getting into a quasi-adversarial position every time with the entity that's sort of paying for your care and that doesn't seem, you know, maybe doesn't seem exactly as disinterested as maybe they might be in whether or not you get this care, since they're going to have to pay for it. So this, we're going to be doing a lot towards modifying delivery systems, sort of regardless of what happens next week. There's a lot of money on the table. There's a lot of energy around a lot of issues in the delivery system. And I think people are very interested in improving the delivery system. Excuse me. Okay. In improving the delivery system today. And one thing that I would put out there is that if we can and we should engage the consumer in a more direct way. Now, there's a lot of attention paid today to getting information down to the consumer. There was a recent study about letting the consumer, posting your chart online so you can make sure that they got it right? Or getting you better access to information, better quality information, comparative information that it's easy to compare from one plan or one insurer or one place to the next. But I would suggest that maybe we ought to look at a way to make that a circle. And as problems arise, is there some other way that we can move information up, other than case by case by case, appeal by appeal by appeal? Fortunately, I think, I don't think I'm the only person thinking about this. There is in the Affordable Care Act funding and the provision for something called the Patient-Centered Outcomes Research, which is in part came into being, I think, out of the concern that, okay, when you care for the average, if your studies are addressing the care of the average person, what about subpopulations? What about this person who's the outlier over here? Are they getting the best possible care? And these questions really, to my mind, really call into question the consumer participation in the process. Everybody agrees people can live healthier and they should live healthier. And a whole lot of that healthy living occurs outside of the doctor's office. We as a society have to look at and have the experts look at how do you structure the community in such a way that it is a healthy place. How do you make sure you have parks? How do you make sure that you have available time at work and are reinforced for healthy habits? But the other side of it is, I think the consumer actually has the capability of making really hard choices, and they bring judgment. I've seen them do it. They may bring judgment every day to really hard questions that they're confronted with, medical questions, technical questions. And I hope that as we go forward, and I think I may even beat my time here, as we go forward, we give some thought to how we can structure participation by the consumer in their health care and in the healthcare decision-making, so that it's not perceived as you're telling me how I'm going to get healthy, but rather I actually have some say in the system. And if one got some say in the system, if the individual becomes engaged in their own care, I truly do believe they'll accept some of these hard choices that may have to be made down the line on the care side. I'll just conclude by saying, this was about health and politics. That's a really big stretch, right? But those issues they intersect at the science and art of medicine and politics. This is why this is such a huge issue. It's hard to think of another one that is as important to the individual. And I would submit, we're not going to get to these things if we don't involve the consumer in a productive way and give them the opportunity to speak up their choices and listen to those choices, to pose the research questions, to have the research questions analyzed. And hopefully that's what the Outcomes Research Institute will look at.
Thank you. Sure.
I only want to bring this up because I couldn't possibly allow us to end on any sort of happy note. Regarding Medicaid expansion, and since Alex and Leslie have both brought it up, one of the pillars of the PPACA, Obama's Health Care Reform Act, was to expand Medicaid at the state level to expand coverage for the poor populations of the United States. Did you respond to that? Obamacare was going to, depending on how you look at it, incentivize or coerce state governments to cover up to 133% of the federal poverty level, which when you're a state like California, which currently covers through Medicaid waivers 106%, or a state like Minnesota, which covers 215% of federal poverty, you're still quite poor, didn't seem like a big deal. Arkansas covers 17% of the federal poverty level for the working poor in the state through Medicaid. Florida also covers below the 100% threshold for many of the Medicaid populations. And after the Supreme Court issued its ruling, this was a devastating blow to the rollout of PPACA, partially because Obama was quite confident that state governments would still be foolish to turn down the money free from the federal government to expand Medicaid expansion. Guess what? Southern and other state governments were quite happy, or in the current fiscal climate, quite concerned enough about the dramatic increase in state expenditures of 10% to bring yourself up to the federal threshold where they would start matching your dollars, that they are not going to move on Medicaid expansion. So Governor Rick Scott in Florida has turned down the expansion, and other states are likely to follow suit. So we're going to see under-provision of health care for the poor across U.S. state level governments following this.
Thank you. So at this point, we are going to open the floor for questions, and if you have any questions, just go on. I just have one recommendation. If we can keep the questions short, maybe 10 seconds. Thank you. And you had your hands up first.
Yeah, just comment and a question. I'll keep it short. I want to be provocative and point out that it almost seems that healthcare in the United States is hopelessly flawed. In comparison to our European comparators, they spend far less, but indicators of health are far better than ours. And it strikes me that as you sort of go through the different presentations, it's pretty clear that there appears to be a very corrosive incentive in healthcare in the United States that drives the politics. So in your case, you mentioned how Medi-Cal now has shrunk to a very limited band of people. Alex, you mentioned that basically your ability to pay dictates the quality of long-term care that you'll enjoy. I think, Ralph, you observed that medical students now graduate with over $100,000 in debt, right? Which also, I think, creates a sort of incentive to practice a certain type of medicine. And Graham has mentioned that some states have a completely different philosophical view about the role of the state government in providing care to the injured population. And so it makes me wonder if we can ever reach a point, I can't remember the question, will we reach a point where we will deliver the care along the ways that you described, Ellen?
I would say yes. No, just say yes.
So, am I supposed to answer this?
Yes.
I'm not sure. That's a very good question. I think I think you raise so many of the complexities of this, and I think we still have to work for it. But I don't know. And as Graham says, even with the Affordable Care Act, it's not the panacea because of all of these other issues. So, you know.
And I'd like to add to this that I have lived in 4 different countries, and I have been exposed to the healthcare in UK and France. And this country has the highest, I mean, when it comes to healthcare, we spend the highest, but if you look at the research, the outcomes are not any better than any other countries.
It depends on what outcomes you're looking at, too.
Yes, it depends.
Let's be really honest about outcomes.
And I'm talking about the majority of people. I'm not talking about the ones who have access and who can afford, you know, to the best of the best medical care. That's, yes. Okay, so you, and then we go on this side.
So suppose everyone took care of themselves as is recommended here, then what would the last couple of years of life look like? How would people be dying less expensively or better?
Interesting question.
Well, I'm not a physician, but I will share, I think, as a person, sooner or later we get ill. And so sooner or later, the most important thing that I think when a person is getting toward death is palliative care and hospice. And that is when a person is not recoverable for whatever reason, and ideally we're extending the quality of life longer and longer, and people can enjoy their life because their chronic conditions are conditions that are being controlled through help and their own self-help, that they are able to enjoy life longer, but at the time when they're no longer able to enjoy life and their issues, their health issues have become so acute that there's no recovery, then palliative care and hospice care are the comfortable way to get to the point of death, and hopefully in their home.
But is it different if I do this at age 75 than at age 95?
Is there a difference? I think I guess that's each individual decision about, or feeling about, how they can have a quality life.
If you check out 20 years early and you've decided, then you perhaps have deprived yourself of seeing your second, third, or fourth grandchild, seeing a grandchild get married, I mean, you know, it's a wonderful life if you have someone to love and something to do and something to look forward to. And if you've got your health, why shouldn't you live to age 95 and enjoy it? But you didn't elect to come into this world. None of us got to vote on that. But damn it, you ought to have the right to decide when you want to get out of this world. And it should be your right as a citizen to make that decision. And I think that's extremely important. You know, and there are certain times when you will get to a point where you go, you know, I'm done with this. I'm ready to move on to the next thing. You should have the right to make that decision. But yeah, I think it'd be great if some people live to 95 and you're healthy from 75 to 94 and a half, and then all of a sudden, for whatever reason, maybe your heart gives out or something else like that. But yeah, I think it'd be wonderful to be able to live that long as you've got your health.
We have one question here, and then I'll go back to that. Yes, Dr. Miller.
Here?
No.
A brief comment. If we are successful in extending life, the overall cost of medical care will increase, not decrease. The second thing...
I don't agree with that.
Well, you have a right not to.
Yeah, and I don't know. You know, show me the data. Show me the data. Show me the data. That's all. Show me the data that if you live longer,
That's what I'm asking
it's going to be a problem. Well, you made the comment, so you've got to prove it. I don't have to prove anything. I just have to disagree with it. But, you know, show me the data.
What I would appreciate is if each of the panelists would comment on their view of the long-term effect of next Tuesday's election. If Obama wins, what is likely to be health care in the United States 10 or 20 years from now?
So how about if we do this? Because that's a very good question. How about if we give you another 10, 15 minutes to think about the answer? Because we are going to have a wrap-up statement by each panelist, and then you can present that. But John, you had your hand up, and then Jody, right after John.
I have a bias too, and it's clearly not your biases. This is a question really for the political scientists. The simple fact of the matter is that 5% of our Medicare population consumes 50% of the resource. On the commercial side, somewhere between 5 and 7% of the population consumes 50% of the resource, which means that 95% of our population is struggling with the other 50%. Now, the real question, I think, from a political standpoint is, how can we rationally deal with that 5% that costs us so much money, and is there a way to do that that would be politically palatable?
Did I mention I'm an assistant professor? That may be well, but I have a few ranks to progress before I feel I can answer that. No, I mean, one of the themes that's emerging that we haven't talked about in this room is the question of rationing and rationing of care. And one of the things that I remark upon when we make comparison with other countries where we claim there's healthcare rationing is that the United States has quite an efficient system of rationing. We ration by the almighty dollar. We do ration, we just deprive care based on one system as opposed to another. And how do we deal with the high costs associated with Medicare patients at end of life, right? I simply don't have the answer other than to say I've yet to hear the politically palatable response to that question. Partly we attribute to the US electoral psyche. We want the maximum benefit of care, which can be provided, if it's provided at all. And that creates a very, very difficult trade-off for the American voter, because we often find ourselves, the majority of the voting population actually does tend to be in a fairly good healthcare situation, of voters, not of the population, but of people who participate. They don't want to depart from what they have. And when they arrive as voters onto Medicare, they also want to ensure that they have this maximum provision of care. So it's a very difficult trade-off to ask a voter to make. A non-political scientist is interested in making a response?
Well, no, I think, John, two things. One, we need to manage the environment, and we have not done that. And I think a lot of these people, the 5% that take up the 50%, they get discharged from the hospital, they come back. They get discharged from the hospital, they come back. And no one's paying attention, if you will, to the environment. And a lot of that could be eliminated if indeed you had, whether they're visiting nurses or just health catalysts or health coaches assigned to those individuals to visit them on a daily basis to help improve the environment. I mean, you say, okay, well, you should become a vegetarian. You go, okay, great. What does that mean? What am I going to make for dinner? What do I buy at the store? How does this work? If you had somebody who would go shopping with you with a list of things and a whole list of recipes and said, okay, here's what we're going to buy. Here's a whole bunch of things you can make. You've got a family of 4. This will feed your family of 4. And this is what you can do with it. You begin to change that environment. And then these people will not be coming back into your hospital over and over again. Right now, we're getting punished for readmissions. Well, you're getting punished for readmissions, but you're not allowed to control the environment. This is an insane game. So somebody goes home with congestive heart failure, you've taken off all the weight, you've got them on their diuretics and everything, they go home and they decide to stop this medicine because it's not palatable, and by golly, if I'm going to have a margarita, I want salt on the rim, and I don't care if I get an extra few pounds, and they're in congestive heart failure and they're in your hospital again. The other thing is, I think we need to put more and more emphasis on hospice. Beautiful studies showing that indeed for patients with cancer that is metastatic or what have you, patient comes in the hospital, gets all the chemotherapy, $30,000, $40,000 a month for an extra 3 months of life. Beautiful study, I think it was in the New England Journal, showing that patients with similar disease in hospice live just as long.
Or better.
longer.
Okay? So we got to begin to think about what's the difference between caring and care. Caring is inexpensive. Care costs a lot of money.
Which I guess is the source of my question. If that's where the money is, why don't we attack that?
Yeah. I mean, think how many visiting health nurse visits you could pay for 1 month of chemotherapy for one patient.
I think there's a model out there that Blue Cross just paid $800 million for a very few number of patients, members that they had, and it's CareMore. I don't know if you've all heard of CareMore. CareMore is a model of insurance coverage. But it's a care model, and the model is one of, for those who are chronically ill, for those in their seniors primarily who are in the chronically ill area, they really provide the service of accessibility to physicians, accessibility to exercise, accessibility to nutrition in a manner that keeps, they are the ones that cost the most money. The dual eligibles is oftentimes what they're called, but or like them. And that's a model that is really an incredible model that I think is going to take shape here in the United States over time.
Terry, can I say thank you on 2 levels? One, I never thought you would ever say anything nice about capitation, so God bless you there.
Yes.
And secondly, thanks for recognizing my staff who put together CareMore.
Yeah, well, I think it's a wonderful, it's an outstanding organization. Look it up, because it's really worth seeing what that model's all about.
And
by the way,
that model, by the way, was San Antonio, Texas.
Is that right?
Yes, sir.
Oh, well, excellent, excellent. And you know, I am a fan of capitation. The system is not there yet. Kaiser does a fairly decent job in capitation. Others are doing a better and better job in capitation. And that's when I talk about population health, I'm talking about capitation.
Sure.
But can you capitate on medication? Can you capitate on equipment? Can you capitate on those products that cost much more than provision of care by a provider? Like, for example, in my practice as a neurologist, I pay $8,000 on a patient to have intravenous immunoglobulin, $3,000 a month before a MS patient. Aspirin used to cost less than a penny. Now we do triptan for $20 a pop. So can you capitate on the part of the expense in medicine that is really so tremendous and so significant? And the other issue, when we talk about care being better in Europe, I just had a patient last week who came from the UK because the doctor won't talk to him. There's no personalized care, and the American philosophy, and I wasn't born in the United States, but I think it's adorable to see that it's a one-to-one, it's a humane touch, it's a personalized care. So I'm going to capitate all of this. So what are we going to do about all of this? How about the kids on the block? How about the new inventions, the new things? The Affordable Care Act, which I'm very fond of, is going to account for the new discoveries and the new provisions that are very significant and tremendous.
You know, that's a good question, because a question that I would have, and I'll bet you Dr. Klayman has, is how are we going to pay for education, medical education? How are we going to pay for medical innovation in this system? And we have to find, and will this system allow for that? The Affordable Care Act. And so those are questions that we have to find answers to, because we have to keep those going.
I have one question here, and then we go to Dr. Burton.
Okay, a couple of things in terms of your comments. First of all, one of the things in this country about weight loss and weight gain is that we do an awesome job of promoting weight loss. And then when you get to the right size, we never say to you, Dr. Klayman, you look great. You have been the same size for the last 5 years. Isn't it wonderful that you keep your weight off? And therefore...
Is this being recorded?
In this country, Grant, you have to be incredibly negligent to either need an abortion or to smoke cigarettes. There's plenty of warnings on the side of the cigarettes, and I am well over 30 years out of school. And when I went to school, there was plenty of information on the problems with cigarettes, and there's plenty of education, affordable birth control, and many, many ways to do it. So we have a population, a system that suggests that it's somebody else's problem, not my problem, to take care of myself, and somebody needs to fix it. And that's not saying I don't believe in abortion. I'm so pro-abortion I believe in aborting the mother sometimes, but that's a whole different story. So
that goes back another generation. This is getting very scary.
But my question is, you suggested, and I see that you are not a scientist, but really an advocate for your side, because a scientist can see both sides. But I'm going to ask you anyway. You said that so we had education, and education has failed. It's been going on for 30 years. It's actually been going on for 45, 1965.
You mean preventative public health education?
Yep. And it happens in the schools, and it happens again in 10th grade. It happens again on the wavelengths and everywhere else. But you suggested that Obamacare passed in 2 years because they saw a window of opportunity, yet everybody in Congress admitted that they were going to pass it and then read it. So that would be, in my mind, a neglect of responsibility. You suggested that in writing this legislation, you needed policy experts, and that there was a deficit at the state level in expertise. And I would like to ask you exactly how would you define expertise in writing policy when you've got the experts, so to speak, lawmakers, not reading what's going on, not spending the time writing what's going on, and then suggesting that maybe somebody implement it.
Oh, I'm thrilled. And first of all, somewhere in my jumbled presentation, I sounded partisan, and that certainly wasn't. Yeah, I came across. I apologize. That certainly isn't my intention. And with regard to Obamacare, when I said they pushed it through with the window from the window of opportunity, I simply said that strategically, given unified Democrat control of government, they were going to pass this bill however they could. And this is strategic because a unified Democratic control knew Obama was going to hold the White House for the 3 years following, the 2 years following. And because he controls bureaucracy, he could direct his appointees to implement the provisions of Obamacare after Congress had been taken over by Republicans, right? So it was strategic.
Well, it doesn't matter who takes it over. What you've got is a bill that's not suggesting anything.
I think
but a bunch of people who aren't experts. Tell me how the experts are going to be
So that's not true. The bill does a lot. So there's a lot that's quite useful.
And then when I was talking about the role of experts in the policy process, I'm talking about the apparatus of support of state government, the research expertise given to staff members, given to elected officials to analyze policy. Not all policy members are going to read all pieces of legislation that they vote on. In California, we vote on 6,000 bills every 2 years. There are 120 elected officials in the assembly. Those 120 can't possibly be fully informed on 6,000 bills that appear before them. It's a sad byproduct of the crush of information that an elected official faces. So what we hope is that we support them. We support them with an apparatus of policy experts, and these are appointed by Republican or Democrats who control the assembly, who can provide them with information about the policy and political benefits of policy making, help them understand the intended and unintended consequences.
Not the policy benefit.
No, that's right. That's quite right.
So how is the expert?
So your learning is how a political scientist thinks about expertise. And when a political scientist thinks about expertise, we acknowledge that partisan politicians are going to have questions about the political as well as the policy costs of action. So when I suggest that a Republican state governor who is supported with an apparatus of Republican appointees who are expert in policy, advising him on the costs of Obamacare implementation and the political cost of Obamacare implementation, is a well-supported governor. And I noticed this in Michigan. Michigan was a red state when I was interviewing people there. We had a Senate that was still controlled by traditional moderate Republicans, a House that was controlled by Tea Party Republicans. The Senate had a large staff as moderates that were supportive of Obamacare, although they had been instructed not to mention it. The House in Michigan was utterly hostile to it. But what's important is that they had an apparatus allowing them to navigate the political and policy questions that emerge in policymaking that we now see are deficient in many states. And so when you hear a political scientist advocate for improved expertise in policymaking, know that assumption one is that the mobilization of groups of interest in policymaking is the mobilization of bias. We outright agree with the point you're making, that this is going to be biased information. The question is how, given two competing interests trying to pursue policy change, can we get the best outcome we want? And the point I was trying to make is I hope that there's a plurality of interests participating, that there's a well-supported government apparatus to analyze political and policy costs, and that we arrive at a happier medium than we have in many other states. And that's how I'd respond to that.
Thank you, Graham. We have two more questions on this side, so we start there and then we'll move next. Yes, Dr. Lujan.
So I have a couple of observations and a question. My first has to do with this gentleman's comment. I certainly agree that a small percentage of the population uses up a very significant amount of the resources. I think I would just observe that there's a high correlation with age with the percentage of the population that's using those resources. And the reason for that is, going to this gentleman, Alex's point, we don't have a very good national dialogue on death. And so we have a lot of feudal care that is used in the last year of life that only keeps people in the ICU and does not extend their life or give them a quality of life instead of letting them die with dignity in their homes. That is costing this country a fortune in many different ways. My second observation would be people who are thin and live healthy lifestyles, going to your point and your point, when they get sick, they tend to get sick much later in life. And they get a catastrophic illness right at the end of their life. Whereas people who are obese and have unhealthy lifestyles, they tend to get sick much earlier in life, and they are sick for decades. They have to be under medical care and on multiple medications for many decades. So even if you live longer, if you have that healthy life, I would argue the overall cost of the healthcare system is less. My last point goes to something Terry said, and that he made an observation about Kaiser. So we have models of healthcare in this country which are nonprofit, they're capitated, and patients in those systems get a lot of preventive care because it's in the financial interest of the organization to provide preventive care, where, going to Ralph's point, most of our healthcare system is not interested in preventive care. So you have systems like Kaiser, or perhaps the VA model, and I'll say there are problems with Kaiser and the VA, but they're nonprofit. They want to spend money on preventive care, and they don't have, going to this gentleman's point, which I thought was said very eloquently, they don't have the problems with the corrosive influence of money because they don't have people who are inappropriately financially incentivized. So they don't have the gross overutilization problems in those systems that characterize fee-for-service medicine. So if you believe that about Kaiser and VA, what I just said, do you see some way that the political process could move this country more towards having more systems like Kaiser and the VA system?
That's what's going to happen. I think it's already happening with the accountable care organizations and stuff that are going to have to be created to manage populations. What I'd like to see is the next step, which really is your CareMore or Kaiser, even more so in Kaiser, because I'm looking for accountable health organizations to look at the 95% of people who are not using the 50% of the dollars and focusing on them to keep them healthy. Everyone is focused on that 5% that's causing the 50%. I would like to shift focus a bit to the 95% and keeping them healthy so they don't get sick and they don't have to lie down in the hospital. That's what I'd like to see, and I think we are moving to that. I mean, that's moving from volume-based to population-based health. It's a difficult thing to do, but I agree with you. I think Kaiser's done an excellent job, and the other thing is they're still able to accept innovation, but they study it before it comes in, and they make sure that what they do accept is reasonable to accept. Now, the question, though, then comes up, where does the innovation come from? And quite frankly, biased as all get out, that comes from the academic health centers where you've got individuals whose only desire is to basically help push things forward. And those developments then need to be tested. I think the electronic medical record, which is also a major part of the Affordable Care Act, is a wonderful thing because now you can begin to come to conclusions about which therapies are good or not much, much sooner rather than waiting for one person to have an experience with 200 cases and report it out. You now can tie in the entire nation and basically look at this particular treatment and mine the data to find out whether it's worth a damn and come to a decision in maybe 6 months that it's no good, rather than 6 years. So there's so much good stuff in that Affordable Care Act. It's 1,000 pages long. Who's going to read that? I can't fault a congressman. Some people can, okay? And I look forward to that day when I could read a 1,000-page thing, but you can get a summary of it that's 100 pages. I get a summary of that. And it's amazing what's in the Affordable
Actually,
Care
I
Act.
found the 13-page summary on the internet today.
But it is really transformative.
Foundation, KFF.org. They have a very short 13-page summary. I would like to add a comment, and then we go to your question. I guess a big difference between VA hospitals and Kaiser and even Mayo Clinic compared to the rest of the country is that physicians are salaried. So if I'm a doctor in that system and I order more tests, I'm not going to make more money. So I think that's one of the differences. Mayo Clinic is a brilliant healthcare system in this country, and the physicians are salaried. They are not, so there is no conflict of interest. Physicians are not incentivized if they order more tests or if they do more. It's
The Mayo model and the VA are very different from the Kaiser model or the CareMore model. And I don't think we should lose sight of that. You know, the Mayo Clinic is very much fixated on a population that is extremely well off and that can pay literally 95% of charges. That's a whole different ballgame.
No, but I was talking about the physicians.
The physicians are salaried, right?
Yes.
But
as a retired educator, my own belief is that many of the changes that we need to see come about to make the quality of our health care, 2 words, amenable to the needs of the people, is only going to come over time, changing attitudes, behaviors, cultural values, many, many, many things.
Right.
But in the short run, I look at it as an individual. What irritates, frankly, the hell out of me is at the point that you made, Dr. Klayman. Health is the individual's responsibility, by and large, and that bars genetic ailments and terrible diseases and whatnot. But so often it would seem that lifestyle things impact a person's health, as was mentioned here for decades. What is it that can be done, let's say on these medical experiments that we're going through now, and that's really what they are, that will say to somebody, well, if you want to smoke, and if you want to be 100 pounds overweight, and you want to have red meat every day of your life, 8 ounces a day, and you're going to drink, and you're going to pay for it. You may be able to accept the illness. Maybe you don't mind eating those pills all the time or whatever, but you're going to lose a large portion of your income, or if your medical payments are going to go through the roof, where your neighbors are going to be low, and so on. Is there a possibility of such a thing, penalizing the people who scoff at their own health?
I think that to some extent people need to be educated as to what they're doing to themselves. I mean, you can tax it. I mean, the tobacco tax has basically provided for care for autistic children through the Orange County Families and Children and Families Commission. That money is all coming from the tobacco tax. I think you can tax these things that are making people unhealthy, but you have to realize there are lobbies that are going to basically oppose that tremendously. But I actually have had several conversations with some of my patients saying, you've got kidney stones because I can tell you your calcium's too high, your sodium's too high, and all that other stuff. But the bottom line is this goes along with everything else. And while I'm a urologist and I would just focus on your kidney stones 10 years ago, now I'm interested in the fact that you're hypertensive, diabetic, and hyperlipidemic. And oh, by the way, you've got kidney stones. So I can take those out, fine. But the bottom line is I'm not doing you any good taking them out. The best thing I can do for you is convince you to basically think about going on a vegetarian diet, seeing a nutritionist or whatever. I tell my patients, listen, you're spending $60, $70, $80 a month, maybe $100 or $200 a month for medications that you don't need, so the president of Pfizer can put gas in his yacht. Now you've got a choice. You can continue like this so that he can then travel around the lake in a 60-foot yacht, or you can go on a vegetarian diet and get with a nutritionist and spend that money to basically get healthier, and now you've got an extra $100 or $200 in your pocket, and you can spend it on what you want. And I don't think that very many people really begin to see it that way.
You know, I
think they would see it, though, if somebody in a position of authority could say, well, it isn't $200 or $300 a month. You're going to have to start paying $3,000 a month. If you want to be overweight and eat the chips every night.
I don't think people really.
You're going to pay.
Yeah, I mean,
you know,
can tax
there are
that
some,
more, but,
there are some examples. I mean, if Dr. Klayman says this to a patient and he's so passionate, he may just
the patient never comes back. My practice has gone to hell.
You'll convince half of your patients. But there are a number of examples now of employers when in employee health, where employers are giving incentives to employees to either stop smoking classes and take those the computerized health assessments, and as they improve on those, they either pay less for their insurance. They have tiered insurance payments now. That is occurring here in the United States, and not in a lot of employers, but in more and more employers. So there is that, and so in an employment model that can happen. Can that happen in a public insurance model? That's probably a ways away.
See, that would be tiered because it's pain, economic anguish that's bringing them.
Exactly.
Sure, I'll smoke, it's going to cost me $1,000 a week or something.
If I could just add one thing there.
She's been heard. Can I let Leslie answer first?
Yeah, no, I just want to interject something here, and as I think I said in my original statement, personal involvement is key here, it's clutch. But I also want to point out some research that Ellen actually brought up, and that's research into what's called the social determinants of health. This is, briefly, this guy did research on social people in the public sector employees. They're all in the NIH. He did it over 30 years. He did a lot of people. And what he found was, not only is the person at the top of the socioeconomic scale healthier than the one at the bottom, which you kind of figured, but as you go down the scale, one by one, the health goes down. So this concept of living the healthy life is really a big issue. It's a big social issue. I don't think it's just about getting educated. That's why the education has limited value. So if you're interested in that research, I would refer you to something called Unnatural Causes, which is a video. It's online. You can order it. It's going to be on PBS, or it was on PBS. It has a political point of view, and it can be irritating from that standpoint. But it really makes the case for what is that these lifestyle choices that people make are not as simple as perhaps we wish they were. And so as somebody who deals exclusively with very low-income populations, very low-income, all sick populations, I just got to say, I think we have to be careful about, blaming the victim, basically.
And then we have to wrap up, so go ahead.
Quick comment on that. They have done research on poor communities showing that they have more 7-Elevens, alcohol sold, and tobacco on every corner than in higher end neighborhoods, so I completely agree with that. My question is for Dr. Klayman. I'm currently a 4th-year medical resident at UCI in physical medicine and rehab. My medical education, I feel, was mostly a disease-based model. So, I had to take my own initiative to get training in health. And that took a lot of effort on my end. They've been doing studies on the fact that just sitting in a chair for more than a couple hours a day will increase your mortality.
I'm afraid that everyone in this room is going to die.
Dr. Klayman,
Been here an hour and a half.
Is there something that is being done at the UCI Medical School now to teach medical students the principle of physician heal thyself so that they are better able to counsel their patients? Because like one gentleman was saying, that we have to change our values and our cultures, and I think if physicians are able to do that, then that'll go through. I work at Long Beach Memorial right now. on team conference day, my physicians bring in a box of bagels or a box of donuts.
Oh, they're
And I'm
good
like,
guys.
I look at it and I'm just thinking, this is not promoting health. Half of the nurses are overweight. And, you know, where all of our cortisol is up because we're stressed. I'm like, oh my God, we gotta fill the beds. So there are a lot of economic pressures. And, you know, I try to, because I've studied acupuncture, Chinese medicine, holistic health, I try to put my 2 cents in. But I do know that doctors, because of the way the model is now of just like handing out pills and stuff, in order to pay for their overhead, which is about, can take, you know, upwards of 70% of their income, they don't have time to counsel their patients. First of all, they don't know how to counsel their patients. Second of all, they don't have the time to, even if they did. I also worked at the VA, and I have told them, you need to be on vitamin D, take your fish oil. If you're going to be smoking, you're going to die. I mean, I do all of that, believe me, and I've condensed it down to a 3-minute spiel.
So Dr. Klayman, now you have 10 seconds to answer the question.
Thank you.
What are you doing at the medical school?
Yeah, we are doing that, okay? We take tremendous pride in our school being extremely innovative and creative in that regard. We have just started a whole health catalyst program in our School of Medicine. So we have now, it's an elective, eventually it'll be mandatory, but we have now 20 of our students, 20% of our class basically, being trained on nutrition, exercise, physiology, mindfulness, motivational interviewing, and stress management. Those 20 students in July, if all goes well, are actually going to get deployed into industry, and each one of them is going to be assigned to 20 individuals in that industry to basically, their only job will be to maintain the health of their cohort that they're going to see each one individually every 4 months, every 3 months, to see if that will impact on the overall health of that workforce. They'll see them where they work. I agree with you wholeheartedly. We've done a disservice to all of our medical students because we never teach anybody how to take care of themselves. The headache that Ellen is talking about that she has to take an aspirin for would not occur, perhaps, if you had training in stress management. So the stress that caused the headache, you would basically use another mechanism to diffuse it, and you wouldn't wind up with a headache, okay? So we are starting to do that. I think it's very important. Flip side of the coin, it is absolutely ridiculous for physicians to be taking care of healthy people. They've been trained for 4 years and gone $140,000 in debt to be able to take care of people who are really sick. And so to fill their offices with healthy people is insane. We need a group of individuals, whether they're nurses or whether they're health catalysts with 1 year training after college, who can basically speak to people about nutrition, exercise, physiology, stress management, can do a physical examination, can take a history, and can do a bedside diagnostic ultrasound exam. And if there's a problem, then report that up to a primary care physician, but only if there's a problem. But physicians should take care of the sick, not take care of the well. And we don't have enough physicians. In 2014, when 30 to 40 million people come on the roll, there aren't going to be any physicians for those people. The best we can hope to do is put out a cadre of individuals who will be able to take care of the healthy and keep them healthy. And if we don't keep the population healthy, we are really doomed. We will not have enough physicians.
One thing, I think we should look at interprofessional education, and that way we could really have a more team-based approach where we can embrace all the healthcare professionals, because it's true that there's not enough physicians, there's not enough healthcare providers, and I think that that's how we could really make a difference.
So we are really out of time, and we are going to stay here. I'm sure our wonderful panelists are going to stay here to have something to eat and answer more questions.
Yeah.
But before we end,
I've been asleep for half an hour by this time. I have to I probably will not stay.
So Dr. Klayman will not stay with us, but we would like to end by any final comments, statements, and if you'd like to make a comment, you literally have 20 seconds.
I'm going to take 20 of your seconds. I'm going to say to you the one common theme from Leslie all the way in here, is we need to listen to our patients. We need to listen to the people in the trenches because they have a story to tell. Secondly, when we listen to them, we show them the respect that we want to hear from them. That's how shared decision-making occurs. Because if the patient doesn't have anything to share, their thoughts, then they're not in a shared decision-making. We as a professional know what we should do for their sickness, and we're telling you, and you should do it. We need to give them the opportunity to have something to say so that we integrate what they want from healthcare and what we can provide them. None of us giving up on real good principles, but there's some flexibility. So we can integrate the art of medicine with the science of medicine. And you all really were bringing that out, I think, quite clearly.
But I would like to still ask our panelists if they have any final comments to make, and also answer Dr. Miller's question about next week and what your final thoughts are.
I'll tell you, looks to be a really great panel in the School of Business here, and right after the, right after the election, the speakers are going to speak to why things will change if Romney is elected, and why they won't change if Romney is elected, and why they will change if Obama is reelected, which my guess would be that's where we're going to go, to some middle ground.
I'll pass my time on to the other panelists. You guys have covered the bases. So.
I mean, just don't get sick and don't lie down.
And don't sit for too long.
My only comment would be that I feel like we've become so polarized in this society that, I'm right, and we can't ever we need to find ways to move and make a change and make a difference. And so I think it's really neat that you're all here and you're exploring and trying to figure out your thoughts on this, and we all just need to figure out how we can work together to make progress and not just hold our own opinions and not listen and have dialogue. So this was a good dialogue.
Fantastically interesting. If Romney wins the presidential election, you'll almost certainly see enthusiasm among Republicans to repeal and replace the health care reform. It'll be the rallying cry for the next congressional election. They've protected PPACA through funding so that it would require, even if they try to defund it, extraordinary majorities in the House of Representatives and the Senate. However, given the shenanigans that Obama and the Congressional Senate used to pass Obamacare, there's likely to be some enthusiasm among Republican Senate, if they take control of the Senate, to use the same procedural rules to overturn Obamacare, which could create, from someone whose business is political scientist, a wildly interesting period in American politics.
Well, I don't have anything as profound as that to say, other than that, I don't know, I think we need to go back to a public health nursing model. We actually have a tagline in our nursing program, and it's the heart and science of healthy communities, and that's kind of what our vision is for healthcare. Thanks for including
It's the art of medicine.
Yeah.
Thank you all for coming.